Thanks everybody for coming. All right, so we'll get started here. Appreciate everybody taking time out of their night to talk about atrial fibrillation. And like Cassie said, AFib is no fib, and pretty much everybody I'm sure in the room tonight either knows of someone with AFib or has AFib themselves. Otherwise, you may not have realized the interest in the topic tonight. So atrial fibrillation, as we know, is an abnormal heart rhythm that can cause the heart to beat too fast and sometimes too slow. So how many of you know of AFib going too fast? That's probably the most common. How about too slow? It's probably the least common, but it can be a cause for a pacemaker. So here we see on this little slide here is atrial fibrillation, in which we see that these QRS complexes here aren't lining up. They should be equal here, and we're seeing that there's some fibrillation going on in that short little slide that we see there. What we're looking at here is the electrical impulses coming through the SA node, which is the pacemaker of the heart, from the upper chamber here. This is normal conduction, with conduction coming through very nicely through the atrium and coming down and supplying the left ventricle for normal conduction to allow the blood to flow nicely through the heart. In an atrial fibrillation, this is very scattered, unorganized rhythm. So your heartbeat is directed by this very complicated electrical system. And like we just talked about, the electrical impulse starts at the top of the heart, travels through and causes this regular rhythmic contraction to all the chambers. And so the heart is constantly doing this. It never takes a break. It shouldn't take a break. So with atrial fibrillation, control of the electrical activity in the upper chambers becomes very disorganized, causing what we call fibrillation or fibrillator, this quivering up in the atria. So is A Fib common? A Fib is one of the most common abnormal heart rhythms. It affects over 2.5 million American adults, and this is coming from the American Rhythm Society. And it accounts for approximately 1/3 of cardiac rhythm disturbances and hospitalizations. I don't have the facts up here, but I did pull up some facts today from the American Heart Association that untreated atrial fibrillation does double the risk of heart-related deaths, and it is associated with a 5-fold increased risk for stroke. And according to a study they did back in 2009, so that's been 10 years ago now, it was called the Out of Sync study, but back then only 33% of patients thought that AFib was a serious condition. And less than half of atrial fibrillation patients believed that they had increased risk for stroke or heart-related hospitalizations or deaths. So it goes to show, even back 10 years ago, we had a lot of education to do on atrial fibrillation. So this video is going to talk you through the normal heartbeat and then what happens in atrial fibrillation. So it's going to give you a better visual understanding of what goes on with the heart in atrial fibrillation.
The heartbeat is controlled by the electrical system of the heart. This system is made of several parts that tell the muscle of the heart when to contract. The SA node starts the heartbeat, causing the atria, or upper chambers of the heart, to contract. The signal then travels through the AV node, the bundle of His, bundle branches, and Purkinje fibers. This causes the ventricles, the lower chambers of the heart, to contract. The flow of electrical signals produces a normal heartbeat. Normal heartbeats can be seen on an electrocardiogram, or ECG. Atrial fibrillation is a type of heart arrhythmia, or irregular heartbeat. In atrial fibrillation, disorganized electrical signals originate in the heart's upper chambers, or atria, causing the rhythm to be irregular. These signals come from small areas in the heart, represented here by stars. Irregular heartbeats can be seen on an electrocardiogram, or ECG. Because contractions are not coordinated as in the normal heartbeat, the heart does not pump blood effectively to the body.
So like we talked about before, no AFib, most patients are not aware that they're in atrial fibrillation. And the first indication of AFib may be admission to the hospital or stroke. And other patients are very symptomatic. So some of these symptoms, and some of you might be familiar with these, palpitations, irregular heartbeat. So lots of patients might say initially that they really feel this atrial fibrillation, and they're feeling a racing heart, fluttering in their chest, that sort of thing. Others might present with just shortness of breath, or what we call dyspnea with exertion, where with activity in that, you're not able to breathe as well as you used to. Going up the stairs, you have to stop and catch your breath. You don't have the energy that you did before. Generalized weakness, that fits in that category of just not having energy, feeling fatigued, really not the stamina that you used to have. And it can be something just as subtle as that for the diagnosis of figuring out you have atrial fibrillation. Fatigue, activity, and intolerance. This one is the most common symptom that we see with atrial fibrillation. Lightheadedness, dizziness, and fainting. Oftentimes where it's coming from the upper chamber, this dysrhythmia can cause some fullness in the throat, and then chest discomfort and increased urination, surprisingly enough. So the bad thing about this is that all of us in the room can say we've probably had one of these symptoms at one point. So, but here are the most common. All right, so what may increase your risk for atrial fibrillation? So these are the things that we know of. There are a lot of cases out there that we aren't able to find a good reason for your atrial fibrillation, but these are the ones we look at initially. So structural heart problems, oftentimes we'll have you do an echocardiogram to identify, if we know you're in atrial fibrillation, to identify if this is a source. So valvular heart disease is a common cause, any congenital defects of the heart. Coronary artery disease can fit in with this, and then congestive heart failure. So as that heart function reduces or the systolic function drops, it can cause atrial fibrillation as well. Thyroid disease is a big one. So if you have been diagnosed with atrial fibrillation, we check the thyroid or make sure that has been done. Other metabolic issues and electrolyte abnormalities can be seen, and these can also provoke those symptoms or patients that go in and out of atrial fibrillation. Oftentimes, if their electrolytes are off, it can cause them to have more occurrences or relapses of their paroxysms, we call it. Older than 60 years of age, as we get older, we're more at risk for atrial fibrillation, being a diabetic. High blood pressure, pericardial issues or inflammation in that muscle of the heart or the pericardium, prior heart attacks, having a prior open heart surgery puts you at risk for a post-operative atrial fibrillation, chronic lung disease such as COPD. Sleep apnea is a big one, which is why I included that picture. A lot of sleep apnea patients that are undiagnosed will end up with atrial fibrillation. And those that have atrial fibrillation that have sleep apnea are found that if they're out of atrial fibrillation, oftentimes if they don't use their CPAP device or there's a night that their device doesn't work, they actually can go back into AFib just during that night and not treating their apnea spells. Excessive alcohol use and then stimulant use as well. All right, so here's a good one is afibrisk.org. So this is an interactive tool by the American Rhythm Society, and it helps individuals estimate their individual risk for atrial fibrillation. So it's a fast and easy way. You can plug it in your computer, answer a few simple questions about your health. It's not a perfect tool, of course. It's not going to tell you you have it or not, but it tells you if you're at risk for it and things to watch for and when to talk to your doctor, that sort of thing. All right, so complications from atrial fibrillation. Oftentimes it's not life-threatening unless it leads to stroke or heart failure, that sort of thing. But side effects of AFib, if left untreated, can potentially be life-threatening. And so those are those side effects we talk about. So the biggest one that we talk about is blood clots. So how many people know that atrial fibrillation is associated to risk for clots, stroke? So in atrial fibrillation, when we were doing that fibrillating effect in the upper chamber of the heart, the blood has a tendency to pool in this what's called left atrial appendage, and it can cause clots to form there, and those clots can go out into circulation. And so if the clot is pumped out of the heart, it can travel to the brain and lead to a large stroke, or what we call a cardioembolic stroke or a cryptogenic stroke. This causes about 15 out of every 100 strokes. So to help prevent stroke, we usually recommend that you be on a blood thinner. That's not everybody now. We use a specific tool, and I'll show you in a moment, to judge who should be on a blood thinner or not. That's guided by the American College of Cardiology and the Rhythm Society. But blood thinners that we're familiar with, warfarin being the oldest one, that's Coumadin, probably the most common that we see. And then we've got these DOACs, which are the new oral anticoagulants. That's apixaban, known as Eliquis, rivaroxaban, known as Xarelto, dabigatran, known as Pradaxa, and betrixaban, which is Bivexa. And we don't see Bivexa used as commonly Myself and Dr. Brody, we like to use Eliquis quite a bit. That's one of our favorites. And if you saw us in clinic, we'd tell you why. But these DOACs are getting more popular. You don't have to manage INRs and make sure that you're between 2 and 3, so you don't have to be coming into the anticoagulation clinic. You don't have to change your diet, that sort of thing. However, Coumadin is the only one that we have a readily available, reversible agent for it, and that's vitamin K. The only other one is Perdexa has a reversal agent, but up until this point, up north here, it's harder for us to have that available, and it's a very expensive reversal agent. But the drug companies are working on reversal agents for these right now. So, all right, so here's this scoring criteria that we talk about. We call it a CHADS VASC. And what this looks at is risk for stroke with atrial fibrillation. And this is a scoring system that we use when we're deciding whether we should have you on a blood thinner or not. And if you have 2 points or greater, you should be on a blood thinner. So what we're looking at is if you have a diagnosis of heart failure or left ventricular dysfunction, this is also known as systolic heart failure. We won't go into a lot of detail on that tonight. High blood pressure, that's somebody diagnosed or on treatment. So even though your blood pressure is good now, if you're on an antihypertensive, you get a point because you had hypertension that led to treatment. If you're diabetic, whether you're controlled or not, it still puts you at greater risk for having some blood clots. Having a prior stroke, a mini stroke or those transient ischemic attacks, or some sort of thromboembolism, DVT, things like that. V for vascular disease, this is prior heart attack, whether it be a ST elevation MI or a non-ST elevation MI, peripheral arterial disease, or if we know you have some aortic plaque buildup or aortic atherosclerosis. Age 65 to 74 gets another, is a 1 point. This one's a 2. If you see a 2, it's a double pointer here. And then females, we're just more prone to having risks based on hormones and such for developing blood clots. So just being a female gets you a point as well. So that's just kind of a basic overview of what we look at, and oftentimes in visits I like to go through this with the patient individually to show them how we're getting the idea of why they need to be in a blood thinner or not. Aspirin is typically recommended if you have a score of less than 2. We want you to be on aspirin with atrial fibrillation. Now there's a lot of studies out there that have shown that aspirin alone, if you have that score of 2 or greater, isn't going to do anything for your atrial fibrillation. And we also know for reducing stroke risk, there's really no difference between 81 and 325 milligrams of aspirin. Heart rate. So this is the other one. This we briefly talked about in the beginning of fast and slow. So without treatment, atrial fibrillation can cause a fast pulse rate, causing the lower chambers of those ventricles to beat too fast. So atrial fibrillation has a mind of its own. It can go anywhere from the 110s to up in the 150s, 160s. We call that rapid ventricular response when we have a heartbeat over 100 in atrial fibrillation. It can be a reason that the clinic tells you you need to go to the ER if you had this on your EKG and it was going too fast. When this happens for extended periods of time, the heart muscle becomes weak, compromised, and it can compromise blood flow, causing enlargement and ballooning effect in the heart, which can cause some systolic heart failure as well. So we really don't want you going too fast for too long in atrial fibrillation. So in order to help prevent this complication for atrial fibrillation, we usually put you on a special medication. Our AV nodal blocking agents, such as a beta blocker, metoprolol is the common one for that, or calcium channel blockers such as diltiazem for rate control with this. All right, diagnosing atrial fibrillation. So the basic one is that EKG. That's where we hook you up to those stickers in the clinic. And we hit that printout button and it gives us 6 seconds of time. It shows us what that heart's doing for those 6 seconds. And so those of you that say, I just had one done a couple weeks ago, the reason we say again, because 6 seconds doesn't give us a lot of time, so we like to relook at it. Bouncing off from that, Holter monitors are going to give us a longer period of time, so that's going to monitor your heart. It's a wearable monitor you go home with. You have a little box such as this, you're hooked up to stickers, and that's for anywhere from 24 to 48 hours of monitoring that you bring back to the clinic. Mobile cardiac monitoring and event monitors, those go in the category. We have like a Zio patch right now that's a 14-day monitor. It's just a basic sticker. There's no wires, there's no box, it's easier wearing. We're switching over to a new patch right now that you can change out weekly, that you can wear up to 30 days. And then there used to be a 30-day kind of telephone style monitor for calling in and that hooking up to a landline. That one was very complicated, so we don't offer that one anymore. Echocardiogram, so looking at your echocardiogram, which is an ultrasound of your heart using sonowaves. It's going to look at your whole heart, all the chambers, the major vessels that we can see, the pericardium, and also looking at all those valves. We can see on echo when you're in atrial fibrillation, and it's very obvious based on how your heart's moving during the echocardiogram. And some things when we're in atrial fibrillation can't be looked at as closely as we want when you're in atrial fibrillation, because it does even mask some things on the echo when you're in it. And then computerized CT or MRI of the heart, which we don't offer the cardiac MRIs here. That's done with our partner at the University of Minnesota, out of our main group there. When should I see a doctor? So any of those symptoms we talked about before, you notice a fast heart rate, you're not feeling well, basic EKG to see if you're in atrial fibrillation or not. So anyone with atrial fibrillation or symptoms of concern for atrial fibrillation or have risk factors can see cardiology. So you can ask for a referral to see us to talk about your risk for atrial fibrillation or if you've been diagnosed with atrial fibrillation. Like we talked about before, the sooner the better, because the sooner we can be aggressive with treatment and getting you out of atrial fibrillation, the more likely you are to maintain normal sinus rhythm. And your cardiology team, here it's myself and Dr. Brody, may refer you for more advanced treatment options offered by electrophysiologists. So that's a cardiologist that acts like the electrician of the heart. Is probably the best way to think about it. And here I kind of explained they're highly trained in the management of electrical properties in the heart and the most knowledgeable doctor to deal with the many complex options for treating heart rhythm disorders. And these are the docs that also do atrial fibrillation ablations for us. So other treatment options, and this is going to get into more detail than basic treatment like we talked about before. Blood thinners, we talked about that. The newest thing now is this left atrial appendage closure called the Watchman device. Has anybody heard of this? So what it does, it's this little guy you see right there, that umbrella. It's put right in that left atrial appendage, and it helps prevent blood clots. So this is really good. You have 30 days of being on a blood thinner, and then you don't have to take it after that, and it prevents these clots from happening in atrial fibrillation. So this is going to be for either a patient that can't take a blood thinner, someone who's young and has a very active lifestyle, climbing, at risk for bleeding side effects from the blood thinners. But we're seeing a few more of these starting to come up for many patients that can't be on a blood thinner, don't want to be on a blood thinner, but it's a percutaneous procedure to get that done. Rate controlling medications like we talked about before. Antiarrhythmic medications, these are rate controlling medications. There's quite a few of them out there, and we choose them specific to the patient. Amiodarone is probably the most well-known. Is probably one of the best for atrial fibrillation, but it does have more toxic properties and should be managed by cardiology to just keep tabs on you and make sure that you're safe while taking that medication. But many of the antiarrhythmics do a beautiful job of keeping patients out of atrial fibrillation. And those can be used with or without cardioversion. So oftentimes we'll start an antiarrhythmic and then cardiovert you, because it's going to increase our odds of keeping you out of atrial fibrillation, and then continue that antiarrhythmic for a while and stop it. Other times we might just try cardioverting you without antiarrhythmics on board. Cardioversion is a scheduled surgical procedure that we do, even though it's not surgical, but you do have anesthesia that puts you under some sedation, and then we go ahead and shock the heart to get it back into normal sinus rhythm. And then ablation. So this is where the electrophysiologists help us out, and I'll show you a picture here in a moment of who does our atrial fibrillation ablations at the university. And this is a procedure where they actually go in through the groin, and then they do this, they localize the area of atrial fibrillation and kind of zone it off by killing that tissue or kind of deadening it and scarring it so that atrial fibrillation can't get in there anymore, can't access through that area of the heart. So your heart can't choose that pathway is probably the best way to explain it. So here's our mHealth cardiology team, myself, Dr. Brody, our cardiologist, Dr. Adkison, he's one of our electrophysiologists, and Dr. Rukos, who's also one of our electrophysiologists at the U. Dr. Rukos does a majority of our atrial fibrillation ablations and other arrhythmia ablations such as supraventricular tachycardia, ectopy ablations, things like that. So if you have a patient or you're a patient that may need these more advanced therapies, Dr. Rukos and Dr. Adkison are available via telemedicine consults for us. So you can see them at Grand Itasca through a Skype type of interaction, which works out great. Dr. Adkison also takes the Fairview plane up to our site in Fairview at the Hibbing Clinic, and he's there once a month as well. And he does a lot of our pacemakers. All right.